Hi, Dr. Stephen Allison here, and the next video that we are doing, very welcome, is on the treatment modalities of diabetic retinopathy. So diabetes in the eye, we went through extensively all the pathogenesis and all the things that you can see in the back of the eye. Now, what can we do about it? Now, there's been a massive emphasis in the last 20, 30 years on the treatment modalities of retinopathy. And one of the most important treatment modalities is prevention, is diet and prevention. We have, unfortunately, medicine has emphasized the treatment side of it and not the prevention side of it, but we will address that issue. So prevention, to make it simple, to understand the principle of the preventing of diabetic retinopathy, is what is the most effective way to not get tagged at a fight? What is the most effective way to not get tagged at a fight? Is to learn to jab and bob and weave very well and how to handle the ropes? No, the best way to not get tagged at a fight is to not be at the fight. Don't pitch for the fight. So prevention is everything. Try and not get to the stage where we need to make interventions from our side. Because when I go through the interventions, you'll see there's no magic there. There's no magic. So one must be very careful. Try not to get to the stage where we need to do treatment. So we will still go through a series of videos where we discuss less is more. In other words, low-carb, high-fat diets, eating window manipulation, the way you can handle stress and sleep, and those modalities to try and get you to not be tagged at the fight. And but let's go on to what do we have as medical practitioners, as ophthalmologists, that we can offer a patient that has diabetic retinopathy. If a patient has diabetes, the first thing we must do is put him on a proper diet, of course, is try and not let the disease progress. So good diet is very important, very, very important. The second thing is tablets, in other words, to supercharge the little bit of insulin that there is, and to stimulate the pancreas to produce more insulin. And the third way is to actually give insulin, to give exogenic insulin, to try and keep his blood glucose at a very acceptable level. So glucose at an acceptable, blood glucose at an acceptable level is paramount. So that we have to do before we do anything else, is get his diet right, get his treatment right, and get his glucose under good control. Right. When we have a situation of background and pre-proliferative diabetic retinopathy, we start getting into a stage of ischemia. And for that, we have laser therapy, focal laser therapy, and pan-retinal photocoagulation. We'll go into detail as to how that works in a moment. Proliferative diabetic retinopathy, if there's a lot of proliferation and new vessels forming, we not only have to do a PRP, but we probably have to inject anti-VEGF into the eye. So you've heard of patients that they get injections, a series of 3 injections in their eye because they've got diabetic problems with the eye. I will explain that at length in a moment. Right, so for that you need a bit of background. What is VEGF? VEGF is vascular endothelial growth factor. Whenever there's ischemia anywhere in the body produces a hormone called vascular endothelial growth factor, VEGF. And this stimulates the blood vessels to form new vessels. So there's not enough oxygen in an area, there's an ischemic area. The only thing the body knows is to make new vessels so that we can get more blood there, so we can get more oxygen there. That's how it works, everywhere in the body. And the eye is no exception. So if there's ischemia in the eye, like in diabetic retinopathy, like we discussed, then VEGF gets stimulated, gets secreted, it stimulates the blood vessels, and they form new vessels. Right. New vessels in the eye are not a good idea because they can easily bleed, and bleeding new vessels are in the way, and you cannot see through them. So bleeding into the vitreous, bad news. it can lead to tractional retinal detachment, as we spoke about. So what the exciting part and the massive step forward in our treatment modality with VEGF is that there was an Italian researcher that found a substance that can actually block VEGF, anti-VEGF. It stops VEGF. So they not only isolated VEGF, they actually developed something that could stop it. And the reason why they wanted to do it is to treat metastatic breast cancer. Metastatic breast cancer is a big problem, is always a big metastatic. Any cancer is a big problem, but the premise was that the metastasis needs blood vessels to continue proliferating. So if it needs new vessels, there will be VEGF that it secretes and stimulates the forming of new vessels to feed itself. If we can block that, then we can treat effectively metastatic cancer disease, especially breast cancer. And that was the premise. The studies were done, and it was mixed results. But it at least blocks the VEGF. And then the ophthalmologist said, well, we've got a lot of problems with new vessels anyway as well. So can't we just inject it into the vitreous and see what it does to the vessels that we don't want to form in the back of the eye in ischemic diabetic retinopathy, or in any ischemic situation, like there's some other ischemic diseases like branch vein occlusions and central retinal vein occlusions that create ischemic situations that we can use it for. So what do? We inject it into the back of the eye, and lo and behold, it blocked the forming of new vessels. What a massive step forward in the treatment of diabetic retinopathy. So that's what those injections are that are given to patients with ischemic diabetic retinopathy, is anti-VEGF, Avastin. It's an anti-VEGF. So in other words, we inject it straight into the vitreous, and there it blocks the vascular endothelial growth factor, and you have less neovascularization. Obviously, you've still got to prevent the ischemia from happening. So that's the other modality, and it's a little bit more of a traditional modality, is laser therapy. Now, laser therapy sounds very 21st century, very out there, very, we can put a man on the moon, and we can send a man to Mars, and we can create artificial intelligence. We're really at the cusp of massive things. So, and we're going to do laser therapy in the back of the eye. Now, it sounds wonderful, but laser therapy is just a fancy word for let's burn a little bit of the eye. In other words, let's amputate a bit of the retina with a laser so that we can turn ischemic or screaming for new oxygen sections of the retina. We can kill that off so that we can redirect the oxygen to the area that can still see. So in other words, it's a very fancy way of amputating some of your retina. And when you say it like that, it sounds a little bit less 21st century, doesn't it? So in other words, it's no better than amputating someone's toes to save his foot, amputating his foot to save his leg. This is the same thing. We do a PRP, pan-retinal photocoagulation, which means the areas outside of the arcade, because remember, in the arcade, here's your optic nerve, there's your vessels, there's your macula. That is where 80% of the vision takes place. So everything outside of that, we can actually kill off to redirect the oxygen to the area that's so important. So we are, in effect, amputating a big section of the retina to save the important central part. So it's not as 21st century as it sounds. So my message, my take-home message there is, don't say, diabetes. It's not so bad. I'm taking my tablets. I'm giving my injections. And if there's trouble, there is laser. They can always do laser to fix me. No, you don't want to get to the stage where you need laser. Try not to get there, because it's a fancy word for amputating a certain section to save the next section. And unfortunately, as we know, the retina, once it's dead, it's dead. So once we've amputated it, there's no coming back from that. So we have anti-VEGF, which is a wonderful, wonderful tool, which is injections that we give in the back of the eye to stop neovascularization, and photocoagulation to kill off shouting ischemic retina, because that doesn't shout for new oxygen, doesn't create new vessels, and we have redirected all the blood supply that there is to the important part of the retina. The next modality, of course, is if there's a vitreous bleed, to do a vitrectomy, take out the vitreous and all the bleed, and that also helps, so that tractional bands do not form. When tractional bands do form, you get the pulling off of the retina, and you get a tractional retinal detachment. Of course, you have to treat the retinal detachment with very extensive surgery. Neovascular glaucoma, a terrible disease. Once there is new vessels that form right on the iris and into the trabecular meshwork and create an increased pressure, trouble, big trouble for that eye. Sort of anecdotally, VEGF does help for that, because it does decrease the forming of new vessels, but you certainly don't want to get to that stage. So the other thing, of course, that diabetes causes, that's not in the retina, that's in the front of the eye, is the cataracts, is basically a coagulation of the lens material, which like the white of an egg that you throw in a pan. You throw it in a pan, as it coagulates, it goes white. And if it's white, you can't see through it. That's basically a cataract. So a cataract doesn't grow. A cataract exists in the lens. The lens material coagulates and goes white and is in the way. And we need to go in, take out that coagulated lens material and put a new lens in its place. So cataract surgery, very effective surgery for cataracts caused by diabetes. So that's at least a treatment modality that's very efficient and very cost effective. But the others, the VEGF and the laser therapy, are really things you don't want to get to. You want to prevent this disease. This is very important for me. That I see this too often, that people are laissez faire about their diabetes, and that, you have got laser, you can fix me with a laser, and you have got these injections you give me, that will fix me, so I can just carry on and not prevent this disease. No, we need to prevent this disease. It's a very, very important concept. So our treatment modalities are state of the art, and they are very expensive, and they are effective, but they are end-stage treatments, and we need to focus on prevention, on not getting there. So please, it's very important to not teach someone how to bob and weave and jab and use the ropes to not get hit at the fight. Try and teach him not to be at the fight, because everybody that didn't pitch for the fight never got tagged. So if you're not going to allow yourself to have a bouncing around blood glucose, you're not going to get eye problems, kidney problems, toe problems, and all the things that go along with it, if we keep good control. So join me in a next series of videos about prevention, about trying not to get to the stage where we need all these state-of-the-art treatments, because it's very possible and exciting, and it's going to lead you into a healthier, leaner, diabetic-free life. What a pleasure. Join me for that.